going on with our society, just to give you an idea. What are the things that we were able to do? We defeated the proposed, or we increased the visibility of World Hearing Day, and that basically let everybody know that we have March 3rd as World Hearing Day. That's not a huge one, but we did get rid of the IPAB board, which is the Independent Payment Advisory Board. That was part of Obamacare, and we were able to sign that into law and to get rid of the IPAB board. They were the group that were going to be allowed to give funds in the event that we were over, if Medicare went over their projected budget, and they were able to cut Medicare payment to the physicians indiscriminately. And they could not do anything to the drug companies and or the hospitals. So we eliminated that. We defeated the proposed cuts to the Medicare physician payments, the SGR formula, and the misvalued codes, and we basically had a provision that was successfully removed in February that allowed us to basically eliminate the misvalued codes. We did the EDDI program, that's the Early Hearing Detection and Intervention Program. We funded that, or we were able to get funding through that. So that was good for our patients. We ensured key patient protections and over-the-counter hearing aid proposals. Basically, we have an amendment that says the medical treatable causes of hearing loss. We added that to the legislation for the over-the-counter hearing aids, basically telling people that if you have a medical treatable cause of hearing loss, you should see a doctor and get it looked at. We led the coalition for audiology scope of practice expansion. We're still fighting this. We've spearheaded the opposition to audiology because audiology wanted to be considered physicians so they could be the point of care people that could write for hearing aids and give people hearing aids without having patients evaluated by a physician. So we're still fighting that, and that's an active work. Scope of practice, we're still doing that, like I just talked about. The EHR vendors, we are strongly opposed to obstructing practices of the ER vendors that want to take money from us to share our information with our third-party providers like Regent that we have within the ENT world. So we're working on that. We don't quite have that. The ENT Pact was very successful. We raised about $20,000 during that weekend, and all this money goes not to specific areas. In other words, not to all Democrats, not to all Republicans. It goes to people who listen to us and hear our voice. It's nonpartisan, it's issue driven. So if you can contribute to the PAC, please do. There's 150 physician volunteers monitoring the legislation across the nation and our state trackers. I'm a state tracker. I don't know how many other people here are state trackers. Anybody? Charlie is. All right, I know Cy is, wherever you are. Okay. So if you want to be involved in that, you can look at the various bills that come up and go through them with us, but we're on it. You can have IGO, which is basically a chance to meet locally with candidates or officials in your district. We set that up, and the Academy will help you with that. And our advocacy network is very active and sends you a message monthly and helps you, and as part of your dues, keeps you abreast of what's going on. The state trackers, scope of practice, specialty-specific areas, and broader medicine. These are all kinds of things that we look at, and we're looking at the state trends. You guys can read the slides. I don't have to read them for you. They're also helping with telemedicine, Lamont, and others who are doing that. The Project 535 was my baby until I was no longer on the Legislative Affairs Committee. So Troy Woodard has taken this torch and running with it. but you can have a member of Congress that you can communicate with regularly and let them know what's going on. And that's what the 535 is for. When there's stuff that comes up, you are paired with a senator or paired with a representative, and you get the message out. Please be involved in that. It really doesn't take very long to do that. 3P is working with the Academy, working with United Healthcare on balloon sinuplasty, working with Blue Cross and Blue Shields on the vocal cord insufficiency, the standard of care issues, looking at balloon dilation of the eustachian tube. We were able to reverse the anthem 25 payment reduction, modifier 25, and basically fought very hard to erase that, and so we're working on that. We have some issues that are up and coming in state of Michigan about that and about reduction with the 25 modifier, and I'm sure that Dr. Simmer will be able to tell us more about that as well. Other things, the MIPS final rule, we've had some expansion of low volume threshold exemption by 3 times the amount. We have virtual groups that were created in 2018, helps for small practices, postpone mandates for physicians, and we have maintenance of requirements for the number of quality measures. We have worked with CMS to make this as easy as it can be for us, but nevertheless less onerous, so to speak. So our Academy's done a lot of other things. They make position statements, they do the social economic surveys, clinical indicators, MIPS resources, look at private payer appeal letters, and we'll help you with that. They will help you with your coding. There was a new top 100 codes for our society that was put in the Advocate. If you want to get that list of the top 100 codes and blow it up because it's small and you can barely see it, please go onto the website, and it has the top 100 codes, and you can actually expand it. And that's about it, you guys. They've been very busy from Academy level working for us, and I very much appreciate that. And should you have any other questions, let me know. Thanks.
Thanks, Dr. Sackler. So I have the pleasure of introducing Dr. Tom Simmer, who is the Senior Vice President and Chief Medical Officer at Blue Cross Blue Shield, and he'll be talking to us about upcoming expectations for payment reforms.
Thank you. I do have PowerPoint, but I do want to emphasize that I hope we can just turn this into a conversation as much as possible, and so please feel free at any point to sort of raise issues, ask questions, etc. Do we have the slides available? Is that something I'm supposed to do here? I'm going to press a button and see what happens. Oh, that's the same talk. Do you know if there's another talk listed? They said they have my slides.
This one is not yours?
No, that's the prior speakers.
What was yours on?
Not perforated, not micro. No.
What about this?
No.
Let me grab Karen. She didn't inform us there was going to be anything else.
I actually confirmed with her before. Okay.
Let me just...
It won't be a disaster if we don't have the slides, but I had some really nice cartoons that I don't want to miss them if that's possible. When I saw patients within the Henry Ford Health System for 21 years. I don't currently see patients. But what I wanted to do is just take a different look at the payment models that are sort of popping up all over the place, ranging from Medicare and Blue Cross, and try to explain the context of this. And I wanted to start off by sort of describing the way our thinking is so shaped by the fee-for-service model that we grew up with, so to speak, that it's really worthwhile for us to just reflect about how you can think differently once a payment model changes, because it really is difficult to see how we've been confining ourselves from this sort of thought. So let's start off by, when we think of fee-for-service, the thing that we often don't think about is something that's equally as important, and that's the no fee-for-service world. And that's the list of services that may be helpful in achieving good patient outcomes that are completely not reimbursable. These range from things like telephone calls and care coordination, group visits, team-based care, outreach to patients, the work on the registries, et cetera, that was mentioned earlier. All that is very important, and all of that is part of the no fee-for-service world. And so if the care model that actually works best is team-based care and is a different model, how would we model we want to use, and how can we use the payment model to support it? Because that is basically the challenge. So my job is professional payment model at Blue Cross, and I view the work sort of globally. We don't want to spend all our time billing, and we don't want to spend all our time reviewing the medical records to see what the level of payment should be. We really want to create an overall model that supports the best care model. Oh, yeah. Very good. Thank you. I think you're going to have all this on our website, so I won't go through the acronyms, but I thought it was worthwhile to at least explain them at the beginning. This is my slide saying that the way we're doing it now in healthcare isn't achieving everything we want it to achieve. And if it's close enough to March Madness, this basketball player is wondering what's wrong with his game, and the answer is we've done every test imaginable and you got no game. It's easier than showing all of these statistics on how our healthcare delivery system isn't achieving everything.
And I would argue that the main reason it's not achieving it is that we have a payment model that confines it. When incentives were simple, I don't think of the payment model, as being something that incentivizes. I believe all of you are pre-motivated to create outcomes for your patients that are really good. You work tirelessly to achieve that. I don't need to motivate you. I need to enable you. And if the payment model is distracting you from your primary purpose by saying, in order to do well from a business perspective, I have to do things that are not well aligned with what achieves the better outcomes from a patient perspective. Use any of their energy in any other way. So the reality is that we've got to not just treat the symptoms, we've got to treat the bigger problem. I like this slide because I just love the look on the turtle's face. And the turtle, I feel that we in the health plan constantly tell physicians, come on, through the hoop, do it. And the reality is that turtle is headed for the turtle soup if they take the encouragement, because there's no way to get there from here. And I believe that reflects the true trade-off when you have our current system of fee-for-service and no fee-for-service. The dilemma is the care model achieving results means you have to be able to measure results. And I'm going to spend a fair amount of time talking about how the system that we're in now doesn't give us the information that allows us to better manage what we do every day in order to achieve what we want to achieve for our patients. So if we go to the root causes, I talked about the malaligned payment. The population focus is a little bit of a surprising one for physicians because they don't really understand how population information can inform the care process and enable us to get better results. And the reason is we're so busy taking care of patients one at a time. In Sweden, the example I like is in terms of how this can inform it. I talked to a CEO of essentially a county household in Sweden, and he told me that they had a goal about 15 years ago, and the goal for their county was to increase the number of people who of millions of dollars because we don't collect it. We don't have a system for knowing. And therefore, we cannot inform practitioners what they need to do in order to improve the health of the patients individually cared for, but guided by that type of information. That limitation of sort of flying blind is not a limitation that we should accept. But under our current model, almost every example that you want to get of getting the information you need to do a better job is almost impossible to get. And I think the issue of MIPS macro measures is something that you that was referred to. The way we're starting off and trying to sort of force it through our current system, while I think it's worthwhile recognizing that this is something that we have to do, it's not going to work until we change the underlying infrastructure. So I will be talking a bit more about the health information exchange infrastructure in the state. I'm not going to focus on the other elements here because I don't think they're as important for this group. But we, in our strategy goals, are trying to just create very explicitly a healthcare system that's able to perform better because the payment model is more supportive of a care model that is innovative and achieves that population, those population results. But we don't think you can really get there from here without making significant investments in population infrastructure, population management infrastructure that includes information. EMR that many of you must use, and how you can get that to work for performance, to guide performance measurement and assessment. And I don't know if you're aware, but the Michigan State Medical Society is working with the sort of standard EMR vendors and MyHIN to get that information kicked out of the EMR after each practitioners who possess an active care relationship with that patient. And what it means is that every physician practice needs to be turning in their active care relationship files. It's called Acres file. How many of you have ever heard of Acres file? So nobody. Well, the care physicians have been turning in that is going to help us get away from patient attribution by health plans and get closer to this is my patient population. And the entire infrastructure across the state for sharing information, that is giving you information or having others access you, is by you attesting these are my patients and sending that into MyHIN. And that is the infrastructure. And what happens is when your EMR is able to kick this out, it will go to MyHIN, but the information will all automatically go to places where it can be assembled to give you your MIPS macro sort of measures and give the supplemental information to health plans and the rest. So it's something to really consider getting on board. It's not something that's really a lot of heavy lifting. The fragmentation of physicians into specialty areas, primary care, and then facilities is a real barrier for us in terms of the payment model for facilities is so different from the payment model for professionals that it's very difficult to weave one in that really promotes people actively working together. And I think that in reality, on the professional side, we have more of a performance-based model. On the hospital side, I would describe our payment model as being you muscle up in terms of your market share and leverage, and then demand more money. And there isn't a performance model that can trump that. It just can't be trumped. And it's one of the reasons why healthcare is becoming so unaffordable in this country. There was a wonderful study in Massachusetts that you can see from, you can Google it. And Martha Coakley was the Attorney General of Massachusetts at the time. And they analyzed their healthcare costs in Massachusetts. This document came out in 2009. It's by far, there's no consultant group, Mercer, or Deloitte Touche, or McKinsey, or any of them that's come out with anything as close as this. It's really, really good. And 80% of the increase in healthcare costs in the state of Massachusetts over a 5-year period, 80% of the increase were related to price increases at facilities. that exactly mirrors my experience that I see happening for the last 15 years. Virtually all of it. And one of the ways that you look at, do you have a good payment model, is you look at what people are doing. If people are all, I mean, you have McLaren Hospital. I think many of us can remember the day when McLaren Hospital was a hospital in Flint. And what have they been busy doing?
And Blue Cross is eventually